Okay, hello and welcome. Very good evening to all of you. It's COVID-19 in India, Trends and Imperatives. This initiative is brought to you by Swasth, a not-for-profit consortium of healthcare players, and IndiaSpend, a data journalism initiative, that's us, to bring you Sabse Pehle Swasth. It's a consumer awareness series on everything you need to know about the latest developments around COVID-19 in India today, but from a more specialized perspective. And this virtual series hopes to give you in-depth information on all and every question that you have by industry veterans and experts, specifically today, epidemiologists. So before I come to that, a quick background on why this and why now from a contextual point of view. India, as some of you who have been following know, stands at about 1.5 million COVID-19 cases. Almost a million have recovered, and that's the good news. And the total number of deaths stands at around 33,425. But India is now the third highest in caseload after the United States, which is at about 4.4 million, and Brazil at about 2.4 million. India is also set to enter its fifth month of lockdown. While restrictions have eased in many places, including in Mumbai, where I am right now, there is no certainty whether lockdowns will stop or their continuance will slow down their transmission of COVID-19. On the other hand, there is considerable certainty on economic impact, like in many parts of the world. Rating agency CRISIL, for instance, has forecasted a 5% contraction in India's GDP for the full fiscal year and a permanent loss of 10% of GDP. So there is pain across the board in the lives of individuals, families, and organizations. And it's not just those who have seen COVID-19 attack their members or family members or even themselves. So getting back to work is imperative, as is estimating the extent of public health crisis that lies ahead of us. Estimating the damage from COVID-19, present and future, will be very critical in coming months, as will be fashioning our response to it. So what are the trends that we can see now? What are we able to project to the extent that we can project? Can it get worse? Is there a second wave likely? Can we reach herd immunity in time? Can we keep our death rate low? The one question that matters the most in many ways. And have we slowed transmission down, at least in some parts of the country? And finally, even if we slow transmission in one place, could it all change and reverse once people start meeting each other and traveling? So how does the world ahead really look? So we've got three great panelists and experts to talk about this, and I'm going to introduce them sequentially, as each speaker speaks, and I'll give you a short introduction before that. So we're going to kick off with Professor Gautam Menon. And the format is that each of them will speak for about 5 or 6 minutes, and after which it's really the floor that's open to all of you for your questions and comments, and in a manner that we can have an engaging conversation all around. My name is Govindraj Ethiraj, and I'm the founder of IndiaSpend and a journalist by training and background. So Professor Gautam Menon is a professor of physics and biology at Ashoka University on leave from the Institute of Mathematical Sciences, Chennai, where he's a professor in its theoretical physics and computational biology groups. He is also an adjunct professor in the Department of Biological Sciences at the Tata Institute of Fundamental Research, TIFR, Mumbai. He was a visiting professor at the Mechanobiology Institute at the National University of Singapore between 2011 and 13. He works in mathematical modeling in a range of fields, including, of course, the modeling of COVID-19. He is a PhD from the Indian Institute of Science in Bangalore and focuses or has focused on biophysical problems and modeling of infectious diseases, which brings us back to COVID-19. On that note, it's over to you, Professor Menon.
Thank you, Govind. Thank you for that introduction. It's very nice to be here. And you wanted me to sort of summarize my thoughts about where things are going with COVID-19. So I'll concentrate mainly on 4 main points, 3 or 4 main points. The first is that there's been a qualitative change in the way the disease spread through India. For a long time, it was concentrated in basically, in between Bombay, state of Maharashtra, the state of Gujarat, the state of Tamil Nadu, and the Union Territory of Delhi, in these areas. And it's really stood there for a long time. But now the focus has shifted away from, although Maharashtra still tops the league table of countries of states with the numbers of infections. Now you see Karnataka increasing in its numbers, with Bangalore as a particular epicenter. We see the rise of Andhra Pradesh as another center, as well as Bihar, Uttar Pradesh, West Bengal. All of these were states that weren't really in play about a month and a half, 2 months ago. So that has certainly changed. And that I think will be a feature of what happens going on. We've already seen Delhi seems to be cresting at the top of its numbers of cases, and Bombay seems to have seen a very definite reduction in the day-to-day numbers of cases. So I think the course of action will really move to these different states from those that were there earlier. The second point goes back to something that you mentioned, the impact in terms of fatalities. And it does seem as though, for reasons that we don't quite understand, but are probably largely due to the fact that we're a young population, that what's called the infection fatality ratio, IFR, is probably lower for India than it is for some of the other countries. And the numbers that we seem to be seeing are numbers like 0.1 to 0.2% compared to numbers like 0.5, 0.6, possibly even 1 in some other countries. And that's interesting. That suggests that the nature of the impact on India may be somewhat different from that in other countries. What we don't know about, and that's my third point, is what we know about COVID-19 so far is that it's not just that fact that a small fraction of people, a very small percentage of people will die from it, but that it seems to have some long-lasting effects in terms of morbidities. That you do have at least about 1/3 of patients with COVID-19 will probably see effects lasting beyond about 3 months once they've been infected by it, once they've suffered from it. We don't understand what those consequences are in terms of India yet. Do Indians respond in any sort of different way? Is there anything in predisposition, the comorbidities associated with the Indian population that might predispose them to a different set of long-lasting morbidities after the infection with COVID-19? What we've not been thinking about, so now, as you said, we're somewhere between lockdown and unlockdown. We're not very sure where. It's very homogeneous across the country. But we don't have very good metrics that are official and that people know about. For when do we decide to lock down? When do we decide to unlock down? And that, I think, is very crucial. It's not enough, as government seems to be doing, to just tom-tom the recovery rate, because that's probably the least useful of all the measures that one could consider. But we should look at things like test positivity as one example, the growth rate of cases is another example, and to see, is there some combination of these that can help dictate for us when we should lock down a particular region. Of course, a global all-India lockdown really doesn't make sense. Apart from the first lockdown, it's not clear that later lockdowns had any sort of important effect. And certainly the losses from the lockdown, both economic, social, etc., were very considerable. But I think we do need to think a little bit more at this point about what are good indices or metrics that might help us decide when we should lock down and when we should unlock down on a local, region by region, city by city, zone by zone basis. We need to worry a little bit about improving the quality of testing. This is an issue. I mean, the standard, gold standard test is the RT-PCR test. But there's been a rise in the use of other types of tests, the rapid antigen test in Delhi, for example. And for these, there are many questions about both sensitivity, specificity in field conditions as a function of temperature, etc. And we need to understand these better, as well as hike up these measures, the sensitivity and specificity of these tests, to sort of get a better idea of what's happening to disease, how is it spreading differentially in different regions. So these were the main points that I had to sort of bring up, and I'm happy to pass it on to the next person.
Okay, thank you very much. On that note, let me now welcome Dr. Nimalan Arinaminpathy. He is a reader and associate professor in mathematical epidemiology at the Imperial College in London. His background is that he applies mathematical and statistical tools to study the control of infectious diseases with a focus on public health. He's also worked with national TB programs in India and Kenya, and he also collaborates with the World Health Organization Southeast Asian Regional Office and serves as the WHO Strategic and Technical Advisory Group for Tuberculosis. He collaborates with the US Centers for Disease Control on planning for influenza pandemic response in the USA, and maintains an active interest in studying the spread and control of COVID in India. He is a MA in Maths from Cambridge University and a PhD in Applied Mathematics from Oxford University. It's over to you, Dr. Nimalan.
Thanks very much, Govind. And it's a pleasure to join you today. I have perhaps just two quick points to add to what Gautam mentioned. The first one is a reflection on the use of mathematical modeling in a lot of these responses. So as you mentioned, I'm rather involved in modeling the transmission dynamics of several infectious diseases, including now with an interest in COVID. And I know, of course, Gautam and Ramanan have been deeply involved in this as well. And it's been really gratifying in a way to see the explosion of interest in mathematical modeling with the emergence of the novel coronavirus over the last few months. But at the same time, it's also been perhaps a bit concerning to see some of the maybe undue expectations that have been placed on mathematical modeling. The sense in which this might be, for example, an analytical tool that tells us with certainty what will happen in the future. And I mean, perhaps this might be a point that we'll come back to later in the discussion, but I think it's important, it's perhaps an important reflection that mathematical models are really only projections, extrapolations of the best information that we have today. And just to give you an example, I work with some public health bodies in India who are developing their own modeling capacity within India. And I've been fortunate to play a modest role in helping to inform these efforts. And some of the questions that these colleagues continue being asked is, when is it going to peak? How large is the peak going to be? How long do our lockdowns have to be in order to mitigate this level of transmission? And I would say models can be helpful, but not determinative in answering these questions. And there are many uncertainties that we have to grapple with. Gautam has mentioned a few of them, but also at the moment, very fundamental uncertainties to do with the natural history of the virus, the transmission of the virus. We do already see signs that epidemiology in India may be somewhat different to what we observe in other countries. And so these questions will need to be addressed for more robust, more dependable modeling in future. But I think for the moment, at least, mathematical models can be useful as a tool for helping to focus our questions and to focus our thinking. The second point I wanted to make is, so my other primary interest is, as you mentioned, in tuberculosis and flu. And one of the things I've been watching with increasing concern is how much weightage has been devoted, how much resources have been devoted to the coronavirus response. In many cases necessarily so, but diverted from other important disease control programs, including TB, malaria, HIV, vaccination programs for vaccine preventable diseases, and so on. And so I think there's a very important role in these discussions to maintain our capacity and also the infrastructure that has been built up over so many years in such a painstaking way for the control of these and other diseases. So those are my reflections.
Right, thank you very much. Let me now welcome Dr. Ramanan Lakshminarayan. He is an Indian economist and an epidemiologist. He's the founder and director of the Center for Disease Dynamics, Economics and Policy, CDDEP, in Washington, D.C., and a senior research scholar at Princeton University and affiliate professor at the University of Washington. His research on epidemiological models of infectious diseases and economic analysis of drug resistance on public health gets attention from leaders and policymakers worldwide. He served on President Obama's Council of Advisors on Science and Technology's Antimicrobial Resistance Working Group. Dr. Ramanan is an engineer from BITS Pilani, a PhD and Master's in Public Health from the University of Washington. It's over to you, Dr. Ramanan.
Thanks, Govind. Thanks for having me. And so let me try to build on what both Nim and Gautam have said and probably provide some variation here. So first, just to pick up the point that Nim made. Many people are not aware that the ICMR had a paper that came out, I think Feb 26th, maybe March 26th, I forget when, but it was a projection paper which estimated that a quarter of Delhi would be infected by June or July. Again, I forget exactly which date. And it was not very different from the projections that we had made. And the thing that we were not able to get across very well, because I guess we didn't expect the kind of attention that these analyses draw. In normal times, nobody pays attention to them, but suddenly, everyone is paying attention when it's COVID, and I guess we were not prepared for that. Was what would happen in the absence of any intervention. It's possible to predict what happens without human behavior change, but it's not possible to predict what happens when people change behavior, whether through a lockdown or whatever that's it might be. And I think that's the first thing to remember, that models, in fact, Nim knows, the class that I teach at Princeton is really one which is around this, which is that human behavior is an important component of how diseases evolve, and and this is a piece that I guess had not really come through, that we were in a sense a masters of our own fate. But that said, the disease has sort of ripped through, as evidenced by serological surveys, and it's gone through really fast. Now, how do we assess this? The data the data are really weak, I have to say. There are some things that the government has done well, but some things that are not. One is, of course, the fact that, a lot of these numbers get reported in the media not exactly correctly. So when people say India has 1.5 million cases, and I keep pointing out that's not 1.5 million cases, that's 1.5 million reported cases, which is viewed through the lens of one of the lowest testing levels per capita in the world. So we love to see everything, including mortality, on a per capita basis, but somehow when it comes to testing, we don't really pay attention to the fact that it's really poor on a per capita basis. The second is, of course, I think maybe Gautam pointed out that, everywhere you hear of so many people who were cured of COVID, recovered from COVID, I can sort of stomach, but cured of COVID, that's a bit much. We should hope for recovery rates which are in excess of 99%. So a 64% recovery rate or a cure rate, whatever you might want to call it, is not satisfactory at all. And eventually we would hope that all of these folks would recover. However, as you mentioned, this idea of long-term sequelae, because it's a new virus that doesn't know us very well, we don't know it very well, and it seems to attack the neurons, or at least attach itself to neurons. We don't really know what's going on here. And I suspect that we will be learning about this virus for years to come. And just like we have, cohort studies of people who survived Hiroshima and Nagasaki to look at the effect of radiation on their long-term, health outcomes, even today, we would be studying COVID, 30, 40, 50 years into the future to see what happened to people who are exposed versus people who are not exposed, to the extent that we can actually look at some of these outcomes. The last is about deaths. Again, I think deaths have been seriously underreported, and naturally because of a low level of testing. It is simply too early to tell that India has lower rates of deaths or infection fatality rates, because if you haven't tested, how would that be a COVID positive death? I suspect that these numbers will come to the fore, in a year or 2 years from now. And that's the appropriate time horizon over which we measure performance now. We can't really do a real-time analysis of how well India has done at this point in time. And I also think that we may be overstating the level of agency we have over this virus, which is, very challenging. It's really, really challenging, because some things like population density, population education, these can't be changed by any government in any short period of time. This is what it is, and this is who we are. And I think that all things considered, India's response has been quite remarkable, at least from a political leadership standpoint, even if the public health systems haven't always worked. Third is, of course, these facts of, these state level dynamics. And again, I find these somewhat perplexing, because I think the thing to remember here is that the reason we worry about these in India is not even because of the infection fatality rate or the case fatality rate. Even at a 0.2 or 0.3 infection fatality rate, if 1 billion people are infected, that's 3 million people dead. So it's not just the infection fatality rate that makes a difference. It's also the sheer numbers of people who get infected. For the typical seasonal influenza in India, that's about 100 million people. So the mortality numbers are about much, much lower than what we'd expect for COVID. Because this is a disease to which we have no immunity at all, we would be looking at absolute numbers. And I think absolute numbers also are important. Of course, rates are important, but if someone's going to face severe illness, they're not going to be comforted by the fact that the rates were low, because the numbers are actually going to be high. And this is almost like a forest fire which is burning through. And some states like Delhi, they burn through because they have a population of only 20 million people. Now, if Maharashtra had a population of just 20 million people, Maharashtra would also be done with the epidemic by now. So again, we assess too much of success and failure to efforts of particular states without understanding that there are natural features such as lower population that mean that, okay, we're done with it here, but then we have some very large states that we've yet to go through. And so these are not necessarily reflections on performance. And last but not least, I would say, the future is really something which, at one level, it is not hard to predict. India has, had a remarkably strong political leadership, but our health systems have failed us, and at a lower level, our governance and our public health seems to be restricted to a law and order approach. We've used the lathi more often for fighting COVID than we've actually used the public health systems. Now, that's not universally true. Some states have done remarkably well and some have not. But that said, I don't think we have the fine-grained public health infrastructure that we really should have made the investments on. So what I'd love to see is, looking forward, how can we actually use this as a moment of opportunity for changing public health for everything else that doesn't get the headlines, whether it's drug resistance or whether it's tuberculosis or whether it's malaria or dengue or chronic disease. And I think it's important not to lose that moment to use this as a way of saying, listen, health is actually important. Maybe we realize health when we don't have it, and when we have it, we sort of take it for granted. But I think collectively as a country, we need to do that as well. So thanks, Govind.
Okay, great. So let me start off. You talked about burning through, and it's a very visual term and word. But tell us about, and I'm going to come throw this to Nimilan and Gautam as well. What's your sense on where we are today? I mean, the objective of today's discussion in some ways is to do a on-spot assessment of where we stand today. So the big questions are obviously, I mean, have we passed a hump of some sort? Are we still climbing? And is the peak far away? Is there any way to say where the peak is, where we stand right now?
So the concept of a wave is not an epidemiological construct. I don't think there's any such thing as a wave in a textbook. So it's much more the fact that if nothing else were to happen and you had one population, you would see a wave of that kind. But in reality, India probably won't see anything of that kind because it's a summary of many ups and downs. If you look at, say, the effective reproductive number, even for particular districts in Tamil Nadu, for states, they jump all around. And they jump all around because there's a lockdown in response. More cases, lockdown comes down. Then remove the lockdown, it goes back up. So it's not as if nature is taking its own course. We are interrupting nature all the time here. So I think we're going to see a high plateau for a period of time, maybe about, I would say, 3 or 4 months maybe. And then we might get a reprieve, but I don't see any reprieve for that period, simply because the biggest states of UP, Bihar, and to a large extent Rajasthan and Madhya Pradesh and Jharkhand as well have not really hit that high mark. We're now just seeing the APs and Karnatakas, but we're not seeing the really big states where the caseload's expected to be high.
Okay, before I come to Nimilan, this is to invite everyone to please send in your questions. I'm going to start taking them very shortly, and your comments as well on where you think we stand and, of course, how we should be looking ahead. It's over to you, Nimilan.
Thanks, Govind. I'm going to slightly counter Ramanan and ask folks to imagine an epidemic wave, but only for the purpose of perhaps visualizing where we possibly currently are in the epidemic in India. There are, as Ramanan's mentioned, states like Maharashtra and also specific locations like Delhi, where there have been high case counts, obviously a very visible strain on the healthcare system. But what's been really interesting is the recent serological surveys that have been conducted paint a very varied picture across the country. And so there are specific locations where we're seeing a lot of exposure to the virus. And there are other locations, particularly in the countryside, in rural areas, where there seem to have been very little exposure. And so I think the overall picture that seems to be developing is that there do appear to be the places in India that seem to have been exposed earliest, seems to have had the most rapid epidemics that are on the uphill of that epidemic wave, but still potentially have a long way still to go uphill. And there are other places in India that haven't even started on that epidemic curve, but we should expect that should happen at some point in the near future. And I should say, I think as far as I've seen in the data so far, Delhi is the only location that shows a good signal of case counts having maximized and starting to come down again. But again, as Ramanan mentions, a part of this might be to do with the measures that people have taken, obviously, for example, the lockdown measures and so on. And so it's difficult to tell whether the worst is behind us, even in places like Delhi.
And Nim, also to remind folks that it also coincides with a change to the antigen test, which is remarkably poor sensitivity. So we can't really, I mean, I'm not even sure we have a flattening in Delhi, to be perfectly honest.
Okay, Gautam?
Yeah, I mean, I agree with what Ramanan says. I don't think there'll be a classic peak and a decline, mainly because, exactly as he points out, different parts of the country have seen their upswing at different times. You saw this in major cities like Bombay and Delhi. It rose up very rapidly then it shifted to smaller cities, but with a time lag. So once this moves even further out to tier 3 cities, etc., you still get these little peaks overall for India, which will not give you a classic up and down. For me, the interesting thing with Delhi is the question of what happens once you relax a little more. And then, you know, even if you assume that the serological surveys are correct, and if you extrapolate from a figure of 23% from about a month ago, roughly speaking, to now, and say that it's approximately, let's say, somewhere between 35 to 40%, that's still not what it, you know, the limit to what you might predict from a canonical herd immunity perspective. There are more people to infect. So what happens in that case? Do we see a slight upswing if we relax these measures? That's not clear at the moment, and it would really be sort of interesting to find out what might be the case.
The question I have actually to, I mean, in some ways, almost all of you, is that, you know, how do you relate this? I mean, you all have worked and observed many other infectious diseases in the past. We all know that COVID-19 is different, far more deadly, and we know less about this than anything more. And yet there are similarities, and perhaps there are similarities in behavior. So what can you tell us and those who've joined us about, you know, how do they relate to this? I mean, or what is the best way to relate to it in the way its trajectory is likely to play out?
In some sense, it's close to a flu. It's a fast transmitting respiratory disease, but it doesn't have the sort of seasonality that you see for the flu in the more temperate regions of the world. So influenza in the more tropical regions tends to be much less seasonal, much more mixed up, etc. We do have some immunity to some strains of influenza, but it's just that influenza virus mutates fairly rapidly. So it's not a very long-lasting immunity, and it depends upon what changes. We do have a vaccine. It's not used very much in India, but there is a vaccine that's used in North America and Europe against influenza. But it shares some characteristics with that. And also the fact that the fatality IFRs are low for the influenza. But apart from that, I don't see any immediate comparison to anything else. I mean, this is the disease X that everyone has been planning for a while. Fast moving, kills people, hard to protect against, no vaccine, etc. So in a sense, we're in some new territory here, especially with the long-lasting morbidities associated with infection. With the flu, you get it, and then it's very rare for there to be long-lasting consequences. We don't know that yet for COVID-19.
Right. Yeah. I mean, I've been interviewing some doctors who've been talking about everything from, of course, lung fibrosis to neurological symptoms to you know, and I mean blood related. I mean, a whole bunch of things which are residual,
mainly vascular in nature, and of course, there's a probability of Kawasaki's disease in children.
Right.
It seems to be very complicated.
Right. Nimilan, how are you seeing this, and are you able to draw any kind of comparison with anything in the past or what you've seen before?
There are the comparisons that Gautam mentions with flu, and maybe that's the closest one that comes to mind. Attendees might remember the 2009 H1N1 pandemic. That was obviously far less memorable, I think, than COVID will be, but because it was such a mild pandemic. One of the things that I think is quite interesting in contrast to that flu pandemic, or actually, perhaps let me first point out some of the similarities. I mean, it went global very rapidly. There was, of course, no lockdown against that virus, and we saw epidemics happening across the world, but also we saw very pronounced seasonality. And I think for this new virus, especially now that the Northern Hemisphere is going into the usual season for flu, it'll be very interesting to see the extent to which this novel coronavirus also shows some seasonality. Interestingly, the already established coronaviruses, it's very easy to forget that we already have human coronaviruses that have been with us for centuries. Those already established coronaviruses do show some signs of seasonality in temperate regions. And so it's quite plausible that this novel coronavirus may also show some seasonal behavior. But one of the really important...
But we don't know as yet.
We don't know as yet. And perhaps in another 3 to 4 months, we'll have a lot more evidence to be able to say either way. But I think one of the really interesting and very prominent discussions around the comparison between COVID-19 and flu has been the role of school children and younger age groups in the transmission of this virus. And so the classic thing with flu is that school children and younger children tend to be mostly responsible for their transmission. And so vaccination strategies increasingly for flu have been recently focusing on these putative super spreaders. But it seems as though the younger age groups, at least with the evidence we have today, may actually be much less involved in the transmission of COVID-19.
So Ajay Nair asked the question. He says the pandemic seems to look like hundreds of micro epidemics to a non-expert like me, he says, in reasonably defined population groups, cities, districts with drastically reduced but ever-changing population movements between these groups. Given this complexity, how confident are you of models like SAIR models helping us predict, understand what is going on? What tool can planners use? How should they be even thinking about this? Who wants to respond?
I can start off and everyone else can.
Yeah, please.
It's certainly, you can generalize the SAIR model to what are called meta-population models, which really account for that. You can have this sort of lots of little SAIR models communicating with each other through migration. All of that is well known and that's well understood. And some of the models that we work with, which are defined at the district level, put in these things, put in migration according to various approximations that you can make. But that's certainly, it's certainly known. And that point is absolutely right. It does look like lots of different little outbreaks seeded by transport of people moving from one place to the other. And what you observe is the overall large-scale effect on the country the size of India. But this has many consequences. Yeah.
Okay.
And just to add to that, for participants who may not be so familiar about what SIR models are, basically you imagine that you can divide the population into 3 different groups. People are susceptible, infected, and recovered. And broadly speaking, you imagine that people in each of these different compartments are very similar to each other. And so SIR models have been very useful for the modeling of diseases like measles, even flu. And I dare say they have been very useful in examining some of the dynamics around COVID-19, but we're slowly starting to realize that our traditional SIR models, the simplest possible SIR models, where we assume that everybody is similar to each other, are going to need refining, going to need drastic refining. One of the really interesting dynamics that seems to be cropping up for COVID-19 is just how varied infection can be. We're seeing in many other countries, and also now seeing signs of similar behavior in India, that there may be many, many people who don't transmit infection to anybody else, but a few people who actually really drive outbreaks. And in these ways, the traditional SIR models really don't work very well. But there are ways of adjusting these in light of the data. But it comes back to the point I was trying to make earlier that we start from a naive point of view. We use the best available data. That data improves, and as that does, then our models improve as well.
Okay, so Dr. Mahadev Desai says, do you believe the figures declared by different states without giving the breakdown of deaths, non-COVID deaths, hospitalizations, number of tests, and positive cases? Ramanan, do you want to go?
No, because they're all gaming the system, and I think it's something which also speaks to the fact that one of the things I've been uncomfortable with is this government monopoly on the testing, which happened in a very early stage. There was no reason for it, and the fact that, in fact, if I look back and I think, well, what could we have done differently? I think what we should have done differently was really expanded testing in that first 1 month. Like vastly. And India had total capacity to do this. We could have been doing 100,000 tests a day because the capacity exists in the public sector, the private sector. It was laughable when, senior pathologists in the private sector labs said that, ICMR wanted to train them on using the tests before they would be allowed to use the tests. You're like, what are you talking about? In a regular day, these are the guys who provide us with diagnostic services day in and day out. They're good enough for our regular life. And in a crisis, suddenly, they have to be trained to do it. So I think there was a desire to control the message. And I think in that desire to control the message, the data was lost at the very beginning. In fact, we may have never needed a lockdown of the magnitude we had at the beginning. And we had to have that lockdown only because we didn't know where the cases were. if you had known where the cases were, arguably there would have been not that many of those cases because India did respond pretty quickly. There must have been, in March, we probably had, I would say, maybe 10,000 cases max. We could have found those 10,000 cases with, expanding testing vastly, doing our pool RT-PCR, whatever it is. I think we lost that moment. And after that, it's then the downhill because the lockdown also went the other way because it put us into a fear mentality. And that fear mentality now results in stigma coming in the way of anyone wanting to get tested as well. That even if the tests were available, if it's convenient to get, which by the way it is not, that people don't want to be seen as the flat that has a COVID patient, right? And who wants to be that person anyway? So I think a lot of disease is really got to do with, many years ago, we started on this project at Princeton called the information structure of disease. The whole idea that public communication and how information transmits during disease is far more crucial for how diseases transmit than the virus itself to some extent. And I'll just stop with one example. During the Surat so-called plague, one of the first things that the government did was they said, oh, we may have a plague here. What happened? Half of Surat emptied out and went to the rest of the country. So if you had tried to, that is almost the worst message if you try to control plague in Surat, to tell everyone to go somewhere else because they would have taken the plague somewhere else. So I think this is stuff that we don't really understand or do very well. I'm not saying that anyone really does very well, but these are missteps that were a challenge and continue now because now states feel like they shouldn't look worse than other states.
Okay, so Gautam, so given that data is weak and data is being questioned in many countries, not just in India as well. So then how does the job for someone like you become, I'm sure it's tougher, but how tough and how are you adjusting for variations?
So this is really very difficult. I mean, just to give you an example to add to what Ramanan said, all of his points are right. That how it is really very difficult to extract data from government, even the data that we have, it's like pulling teeth. So to give you an example, the data is presented by states in the form of a PDF file that's uploaded every day. You can't access the previous day's PDF file. You need someone to download every day that PDF file. The PDF file is obviously not the best way to extract information from. There's all sorts of complicated things that you have to do with it to get the numbers out. And it's those numbers that are of interest to you. We don't have any information about what the trajectories of individual patients are through a hospital. For example, what fraction of them need ICU treatment, what fraction of them report with what types of symptoms, how is that divided, what fraction of them recover, what fraction of them remain symptomatic, even though asymptomatic, even they were tested initially in the beginning at a point where they were asymptomatic. We don't know any of this, so it's hard to build up a picture of the natural history of COVID-19 in India. But far more than that, it's this reluctance of government to part with data of this form that really severely hampers modeling.
Okay.
And the data that is out there is limited. Sorry, go on.
One is data itself, and the other is the manner in which data is transmitted or disseminated. And that's a problem with government data in many parts of the world. And that's something that we have to work on. Okay, so a couple of questions around where we stand again. Akhil Paliyat asked, many states seem to be seeing resurgence. For example, Kerala, how do we factor in the risk of resurgence in the decisions of opening up? Nimilan, do you want to take that?
Yes, perhaps I could add to that, and it's partly an answer to the previous question as well. I mean, I wanted to echo that data is a problem, but also wanted to emphasize that data is a problem in many countries as well. I think one of the uncertainties, one of the biggest uncertainties we have to deal with is to try and understand what proportion of cases are actually being reported. When we see the reports, we know this is a tip of the iceberg, but we don't really know how large the iceberg is. I wanted to emphasize this is a problem across many countries. But my comment on that is that one of the few elements of ground truth, if you like, that we have so far have been serological surveys. And these surveys, they have limitations that are important to recognize. But to a large extent, they also help us to grasp the extent of exposure in a community to the virus. And so when we look at the information that the sero surveys are telling us, then I think when you are in settings where there's been a lockdown, let's say, and you have a serological survey from that setting that tells you that perhaps 15 or 20% of people have been exposed to the virus. That sounds like a lot, But we also have what is known as this herd immunity threshold, which is the proportion of the population that needs to be immune in order for the virus not to be able to spread in a self-sustaining way. And so 15 or 20% is obviously not as high as the estimates that we find from several studies for the potential herd immunity threshold for coronavirus, which is thought to be around 50 to 60% at least. So in answer to the question, I'd say we should expect to see resurgent waves when restrictions are eased.
Okay. Akhil also asked another interesting question, and which many people ask, is vaccine or herd immunity are only two options, and if so, what comes first?
The vaccine will take at least 18 months. Sorry, I'll go ahead.
Yeah, go ahead.
The vaccine will take at least, I think, very, very lucky 6 months. But that's pretty much, I think, ruled out. It is much more likely to be a year to 18 months from now. And it's whether herd immunity or not is reached before that depends very much on to the extent to which you can sustain measures. If you just let things run as it is, then you will reach herd immunity within a matter of, let's say, 3 to 4 months. It's not clear that you would want to do that, because that's really the scenario that Ramanan, the numbers themselves become very large. Even a very, very small fraction of a 1.38 billion population is a very large number. So you don't want to infect even, go anywhere near that. So we have to keep these restrictions in place. We have to keep distancing, mask wearing, all of these in place. With that, again, it's a very, very big, it depends. So I would rather not think about it. I'd rather sort of feel, because with herd immunity induced by infections, there are a lot of deaths that you just cannot avoid, and we would prefer not to go down that particular
route. Right. So we should
as
not
far
talk
as
about
possible.
herd immunity beyond a point.
By infections.
By infections, yeah. Okay. Here's another question. So since I think there was a reference to Delhi peaking out and sort of crossing the hump, Sashwati Roy asks, how likely is reoccurrence post a peak in a state or smaller geographic areas? Ramanan, do you want to take that, or Nimilan, or both?
I mean, it comes back to the meta-population model. So remember that the fundamental assumption that, one of the fundamental assumptions behind these SEIR or SIR models is a well-mixed populations, that you don't have these clusters which are sitting here and there. And let us just take, my neighborhood, for instance. Here in Vasant Vihar, people have hardly moved out. So it is possible that there's a cluster of people who are uninfected here, and there is enough of a population to sustain an infection. One of the things that you teach in these classes is that a disease doesn't die out when everyone is infected. The disease dies out when it becomes the person that an infected person can reach. For that infection to jump to someone else, that number drops below 1. That's this whole reproductive number business. So you don't have to infect everyone for the disease to die out. However, you can have pockets and clusters where the disease can survive and thrive. And I'm sure there are such pockets around in the city. And so we're not really done with it yet. It will come back, in these pockets here and there whenever there is an opportunity. And I would suspect that these pockets happen to be in wealthier neighborhoods where people have not mingled because they can afford not to. And a lot of the, if you look at the seroprevalence survey from Delhi itself, you see that there's a high correlation between seroprevalence and socioeconomic status of that neighborhood. And that's for this reason. They probably have not had the luxury of socially distancing, and some of the others will have to pay the price later.
So Sudeepta Ranjan Ram asks, is India taking the right measures to stop the virus? Are we on the right track? Is India experimenting with different methods to eliminate this? And let me add something to that. Are you seeing, whether it's in India and whether maybe we can contrast with some other countries, a sense of single direction in approach, in as much as it can be a single direction, which of course could be split into many other things, or is it like a random response divided by geography, vertically, horizontally, and so on?
Should I could volunteer that. I think it's helpful to cast our minds back to where we were in January of this year. And at this time, the novel coronavirus was being recognized. There were news reports circulating that there was this novel coronavirus emerging from Hubei province in China. And at that time, if you had asked me whether it's possible that countries around the world would go into lockdown, I'd have scoffed at the idea. It simply wasn't, it simply didn't seem like something plausible. And I think what we've seen in the last few months, unprecedented is a cliche, but I think it's true. So likewise, again, if we look at our perspective today and ask what will the world look like another 3 months from now, again, it's going to be very difficult to imagine, but my instinct is that we're going to be moving towards smarter containment strategies. As Gautam mentioned, herd immunity is a very painful way of bringing the epidemic down. And we toyed with it here in the UK and quickly decided, perhaps a bit too late, that it wasn't a good idea. But in the future management of the disease, I think there's going to be a lot more interest in, for example, the role of cancelling mass gatherings, for instance, or really promoting the use of face masks and infection control measures, at least as holding measures until a vaccine becomes available, perhaps a year from now. I will say that we don't yet know which of these are going to work. We don't yet know which of these are going to be effective. Perhaps the next 3 months on a global level will be a journey of evidence generation in all of these possible measures.
Ramanan, where are you seeing, I mean, when you look around the world, where have you seen the sharpest strategy in terms of response to this public health crisis?
That's not a fair question, Govind, because others have constraints that we don't have. If you have a smaller population, if you have a better invested public health system, then you can do a lot. And that's why I'm always careful to say, do I wish we'd done better? Yes. But do I think that we could have done vastly better? Probably not. Because many of the criteria for doing better were determined a long time ago. They were determined by our public health system. They were determined by how our scientific leadership works. And none of these are ideal in many ways. But the time, as the former health secretary of Kerala said, you can't build a public health system to deal with an emergency in the middle of that emergency. And so in a sense, we were stuck with this, whatever it was in February. And the one thing that I'm really happy about is that at least on the political leadership side, there was no confusion about whether this was important. The reason why Mexico and Brazil and all have done far worse is because they had presidents who ran around hugging people and said COVID is not important. We don't have to speak of NIM's prime minister or of course Trump, which less said the better. At least we do not have that, and I think state chief ministers have taken this quite seriously for the most part. So I would say, with our constraints, we've done.
Okay, so Ashok Kanfte asks, what is the rationale of the apparently random lockdowns and unlocks that we're seeing in different states? Someone has added to that saying, Himlata says, will this weekend total lockdown help? I'm assuming you're in Noida. And how can we explain Taiwan, South Korea, and to some extent Japan having greatly controlled COVID-19 spread or low death rate in Singapore and I'm sure Hong Kong as well?
I think all of these examples are very different. Sorry, I just
go ahead,
quickly.
Go ahead. I'll let, yeah.
The problem is that all of these examples are very different. I mean, Singapore managed to control it very well until they forgot that they discovered that they had forgotten one section of their population completely, which are the migrant workers who were living very sort of tightly enclosed. Japan seemed to be doing very well. Now the numbers seem to be ticking up again. So it's not very clear whether there is one size fits all. Every country has its very unique problems. Every country is very specific in the way it's done this. The problem, I think, with India's lockdowns is that it hasn't been clear what the measures are by which you decide to impose a lockdown or to remove a lockdown. We haven't, at least that hasn't been communicated at all to people who might want to think about it or to understand why these decisions were made. It may have been perfectly reasonable to do that. It's just that we don't know what logic led to it. Sorry, Nim, go ahead.
Yeah, and I agree completely with Gautam that there are very important between country differences. One of the things to remember about Taiwan, South Korea, Hong Kong, is back in 2003, I think it was. There was the last emergence of a SARS virus, and it caused massive disruption across the region. And it's also easy to forget that highly pathogenic avian influenza was also circulating in poultry at that time, and causing infections in people with 50% case fatality rates. So that region, that area of the world got hammered in 2003 by these emerging infections. And I think one of the really interesting things was what resulted from that was a massive revamping of health systems in that region. So health reporting became much improved, coordinated across different parts of government in several parts of the country. Before the call, Ramanan and I were talking about data from Taiwan. The only reason that we're able to benefit from this data is because it has been improved across the board in direct response to how heavily those regions got hit in 2003. So they were ready, and they were ready when this new SARS virus emerged. But looking to the future, what I hope is, this is perhaps echoing a point that Ramanan mentioned at the beginning, that perhaps there'll be lessons learned not just for the Southeast Asia, but this would be on a global level for the improvement of our health systems and our preparedness for the next emerging disease.
You're on mute.
Sorry, Govind.
Yeah. Here's a question which applies to today and maybe for tomorrow. So the question is from Suraj Nair. He says, the COVID situation has been handled by the Indian Council for Medical Research right from the beginning. Do you think if the National Center for Disease Control, NCDC, India would have handled the situation better?
Yeah, so I'll take that. So it's not a question of better or worse. I think we need a mental approach and a thought process here. And we set up NCDC for this specific reason. We have a field epidemiology training program there for this reason. And you can't, I think one of the things that both our people and the political leadership don't get is that these are not dealt with by doctors. Doctors are not the people who lead in the case of epidemics. It's really people who have a variety of skills. In fact, we can run the entire immunization program without doctors, to be honest. They're very, very useful, but they're only one part of the whole thing. But there seems to be this lack of understanding, and so everyone prostrates in front of where the doctors are, which happens to be an ICMR. There are two agencies that really should have been in the lead here. One is NCDC, which I think is the entity that we should really build up. And we have not, because of the structures and within the Ministry of Health. The other is the Director General of Health Services, which is really the, that's where the entire government response should come from. And in sidelining these two institutions and replacing them with, a medical research institution, I think we have done some long-lasting damage to how we really approach this. And I think we've not had the discipline to really follow our own pandemic preparedness. Not like India does not have pandemic preparedness plans. It's all happened in the past. But the minute there was a pandemic, those plans completely disappeared. I mean, nobody's even paid attention to them. And then it's like a, it's like a cowboy story after that. And I think if we'd had the discipline to say, we follow what we said we would do, and then we do that, I think, we would have used this emergency to build our capacity for the next one. And I still don't think it's too late for that. I think we should still do that.
Right, and that's a good point going forward as a takeaway from our discussion today. Let's come back to the ups and downs and the humps. Vikas Dandekar asks, Mark Lipsitch from Harvard said there are no first or second waves. It's the same pandemic with fluctuations. Do you think we are far from a decisive recovery from the outbreak? Gautam, do you want to go?
We're certainly far away from any decisive recovery, because even if you estimate that the numbers of people actually infected are, let's say 100 million, somewhere between 50 and 100 million, given the sort of the difference between the number of cases you measure and the number of cases that are actually out there, they're still very far away from anything close to herd immunity. So there are many more people to infect. And the idea that there is no single peak, no multiple waves is something that we've discussed. It's probably much more likely to be a peak and a very, very gradual decline interspersed with lots of ups and downs. That also seems to be most likely. Ramanan,
you want to come in on that?
I mean, I think we've already said what had to be said there. I think it's certainly true that it's one.
Okay.
Just to add
Go ahead.
Sorry, just to add a footnote to that, I think what Mark was referring to in that statement was responding to a lot of the discussion that's happening in the US right now, where folks are talking about a second wave. And Mark is amongst many in the US saying, why are we talking about a second wave? We're not even over the first wave yet. In the US, they're facing similar problems as well. But yeah, just to echo Gautam, even in this first episode of this epidemic, we probably still have a long way to go.
Okay.
Actually, just to point out that this is Mark's interview in the New Yorker, which I would recommend people read if you've not read that. This is with Isaac, and in fact, Mark actually says that many of us use I prefer, like Mark does, the forest fire example. The forest fire example is better because at the same stage, a 1 acre property and a 1,000 acre property will seem to have burnt the same amount. You'll say the 1 acre property has burnt a much larger proportion, the 1,000 acre property much less as a proportion. But over time, the 1,000 acre property has a long way to go. We are the 1,000 acre property. And therefore, that's why our epidemic is going to last a lot longer than anyone else's, all else being equal, of course, just because of the size of the population. And that's the reason why Delhi is also coming to an end soon. So I think rather than the wave analogy, I would go with the forest fire analogy because that gives you an idea of how the virus actually works.
So an addendum to that from Deepika Saraf. Dr. Ramanan, it's aimed at you. Do you think COVID-19 will become an endemic disease by the end of the year?
We have no idea. It well could. Here are my worst and best case scenarios. In a worst case scenario, and keep in mind, as Paul Ewald, I think he writes in his book, all disease is a result of misunderstanding between humans and microbes. This bug doesn't know us, we don't know it, and that's why there's all this tension there. And it often kills us in the process of not knowing us also, or we kill ourselves. Now, the worst case scenario is that this is a virus to which there's very little immunity, which builds after the 3-month period, particularly for those who've been asymptomatic. I think that we will have longer immunity for those who've had symptomatic infections, but we don't know anything about the asymptomatics, whether they'll carry the antibodies forward. In that world, we don't reach herd immunity. We keep coming back recurrently to the disease. And we don't do it at the scale of, the 50 and the 100 million in India. We do that at the scale of the 700 million. And in that world, getting a vaccine to take is also a problem. So anytime people talk about antibodies don't hold and say we'll wait for the vaccine, don't realize we're talking about the same thing. The antibodies are what the vaccine is trying to promote as well. So I would hope that these antibodies do form and help us, or the T-cell immunity or whatever else it might be. And the worst case scenario is that both of these don't work, and we might be in for a very long period, beyond a year or 2 years, and then we don't know what's going to happen. The best case scenario is that in 3 months, we're out of it. We hit some sense of herd immunity, and then we don't have to wait for the vaccine even. That's what I would hope for, to be honest. And herd immunity, by the way, is not a strategy again. It is a consequence of the way in which we're controlling.
Yeah, consequence. Okay, so we're running to the end of our discussion. So this was about COVID-19, of course, and trends and imperatives. So we've talked a lot about trends. I'm going to ask all of you to sum up by talking about the 1 or 2 imperatives that you feel we should be focusing on. I think there are many threads of that have already emerged from this conversation. But if you could synopsize for me what you think are the 2 biggest imperatives that we should be focusing on from your vantage point in your expertise. So Gautam, would you want to go first?
Yeah, I mean, certainly one long-term thing is strengthening public health systems. I think we've now realized the value of having an accessible, inexpensive, one high-quality public health system across the world. I hope that is one lesson we don't forget the moment that the pandemic goes away. The second thing goes back to a point that Ramanan made about NCDC. Certainly NCDC should be at the forefront of dealing with a pandemic. But more than that, one has to increase the independence of these government organizations. Their decisions, their public face should not be dictated by what government tells them to do. And you should not have the situation, for example, where ICMR just withdrew and only Ministry of Health, the IS officers were there in the forefront of explaining health policy. This is the job of an epidemiologist, especially an agency entrusted with that job. So in general, allowing more space, latitude, and independence to organizations that are entrusted with response to epidemics is very crucial.
Okay. Nimilan?
We touched earlier on the quality of data. And I think data is going to become extremely important, and we'll have to think more seriously about our approaches to data. But specifically, I think there's a lot of public health action going on right now. There are a lot of measures being undertaken to mitigate the impact of coronavirus, and particularly measures like contact tracing, for example, are generating, I mean, they're being conducted in order to try and limit transmission, but they're generating huge amounts of data. And so intelligent, smart ways of being able to analyze this in such a way that is properly integrated with the way these data are being collected, I think is going to be a very important imperative to help us see the way forward.
Okay, Ramanan, last word.
You know, I think we can always second guess, and I have to say that I have, you know, despite all of what might seem like criticism, I think public health agencies across the country have done the best as far as effort goes. You can't blame them for lack of effort. The kind of contact tracing that has happened in this country is, you know, truly unparalleled. And so we should be critical in order to improve, but not to, you know, not to say that everything has gone wrong. I think some of the stuff is truly amazing, particularly in the South. And I hope that two things happen. One is, of course, apart from what Gautam mentioned, which is that our science agencies gain independence. And I think an independent voice of science is really important, and it would have helped a lot in this situation. Is also for states to be able to take leadership and to do things which are, you know, somewhat different, perhaps as a form of experimentation, and, you know, to be able to lead with the science. That confidence doesn't exist in our states. They all tend to follow, you know, one ICMR guideline, you know, one set of things which might not apply in their specific circumstance. And I think the federal structure of India really could have come through as a strength in dealing with this epidemic, and it didn't. I think finding ways to make that happen going forward would be helpful, not just for this, but for any other problem that involves science, which could be climate change or anything else. So that would be my hope.
Okay, thank you very much. There was another question from Raj Rangarajan in New York about, and he says, how close are we to obtaining a successful vaccine for treatment in India? But that's something that we will hold for our next discussion, which should be coming up in about 15 days. And we'll, of course, be putting it out on social media and sending you alerts. Just to sum up, this was a conversation brought to you from Swasth, which is a not-for-profit consortium of healthcare players, and IndiaSpend. And the idea is to do a status check of sorts on what is happening in the fight against this deadly disease, and to bring about takeaways like the ones you heard in the form of imperatives and action points. That's it from me and all of us here. Thank you very much for your watching, your questions and your comments, and hope to see you soon. Goodbye.
Thank you.
Thanks, Govind.
Thank you.